start taping the program. Once again, this is Dr. Brown of Vinya Behavioral Management, and we are conducting our monthly case study review. Let me go ahead and admit some more people in. You allow me. All right. Today, we're discussing attention and behavior problems in children. It'll be a case on ADHD and Tourette syndrome. All righty. I'll go ahead and get started. Identification. The patient's a 12-year-old Hispanic female in the seventh grade who's being referred by her parents for a psychiatric evaluation. The patient was seen at an outpatient mental health facility where partial hospitalization program and intensive outpatient programs are offered. Her chief complaint is I may be switched to a new school for my behavior, history of present illness. Um, the patient is being referred for behavioral issues in the school setting that may have been occurring since approximately the fifth grade. A few days before the initial psychiatric evaluation in school, the patient became angry and upset with a peer when she was asked to be quiet. She proceeded to call the peer a curse word and whispered under her breath, "I want to kill him." Um, the patient was sent to the guidance office where she was questioned about the comment, and the patient adamantly denied having any intention to hurt the other student, admitted she said it out of anger. The patient was suspended from school because of her comment. The patient denies any access to a gun or lethal weapon, and she denies any suicidal or homicidal ideations. Um, or intent or a plan on initial evaluation. The patient is able to contract for safety. Um, the patient denies that she's ever been violent toward any other individual, yet she's made passive suicidal and homicidal statements. The patient threatened to blow up the school when she was being bothered by another peer during the fifth grade. When she was in the fifth grade, um, the patient, in frustration, will also threaten to hurt herself. Um, the patient states that the parents state that the patient bottles up her feelings. She doesn't articulate her feelings, and then she becomes verbally aggressive. The patient has cursed at friends and has a history of friends telling her they do not want to be her friend anymore because of her behavior. The patient displays signs and symptoms of low frustration tolerance. She is quick to lose her temper. She's easily annoyed, angry almost daily, and sometimes blames others for her mistakes and misbehavior. Triggers for her anger include primarily, as previously noted, annoyed, um, being annoyed by others. The patient has no history of physical aggression toward animals or other individuals. The patient states that sometimes she engages in aggressive play and ruins her toys. The parents state that sometimes the patient will engage in aggressive play and ruins her toys because of her of the rough play. The patient denies either being bullied or bullying others. The patient has no history of fire setting, stealing, or running away. The parent states that when the patient gets into trouble at school, she lies and says nothing happened. And then later in the day, the parents will receive a phone call from the school informing them of her behavior that day. The patient essentially follows rules and requests from authority figures, yet will often need much redirection and reminding to stay on task and follow through. The patient does express remorse at her behavior, calling herself stupid for what she said, and does admit to the regret of outbursts after they occur. Um, and that's the history of present illness. Now, we're supposed to be discussing a case on ADHD, um, but it appears that this patient has a little extra going on, and we're going to talk about that more as the case proceeds. Um, does anybody have any questions regarding the history of present illness or any comments? I personally think that the author here has made an error in in the final diagnosis, but we'll discuss that as it moves on. And I forgot to mention, this case study comes from the book entitled Psychiatric Case Studies for Advanced Practice, and the authors are Kathleen M. Prendergast and Casey Jackman. Just a reference, the book. The book that the item came from. So I'll go on to the past psychiatric history now. The
How
patient was
old is this
diagnosed.
case again?
Uh, um, the patient was diagnosed with attention deficit hyperactivity disorder in the third grade. The parents report that the patient experiences both inattentive and hyperactive symptoms. These symptoms are present in school and at home. However, despite significant symptoms of ADHD, she maintains essentially top grades in science, math, and language arts. The patient has had a 504 plan since the third grade and individualized education plan as well. The patient was tried on methylphenidate extended release for ADHD. The trial was only 1 week long because this medication significantly worsened her tics. The patient was diagnosed with generalized anxiety disorder in the fifth grade. However, she experiences anxiety mainly before a test or when demands are asked of her that she feels she cannot complete. She feels anxious when she has to complete homework. The patient was started on an SSRI, Lexapro 10 milligrams in the fifth grade, and this, according to her parents, has helped her worry less. The patient was also diagnosed with Tourette syndrome or Tourette disorder last year by a neurologist. Physical tics began around the age of 4 years of age, um, where she would experience eye twitches on and off. The patient also experienced a vocal tic, making a coughing sound. So she has both motor and vocal tics. The patient currently has an exacerbation of twitches of her head and eyes when she feels more stressed. Otherwise, the tics do not interfere with her daily functioning. She was medicated. She is not currently medicated for the Tourette's disorder. The patient is currently taking Lexapro 10 milligrams daily, as previously noted, for anxiety, and clonidine extended release tablets, zero point 0.2 milligrams at bedtime for the ADHD. The patient had a 2 month trial in the past of carbamazepine or triliptal for her mood instability, and the parents noted no change with this. It is also important to note that the patient has a history of sleeping poorly. The patient is usually awake until midnight, still very active, and continues to be tired during the day. On a better night, the patient may sleep approximately 8 hours if she's very tired. The patient has had no past psychiatric hospitalizations. All right. And that's a past history, past psychiatric history. Does anyone have any questions about that? Any additional information that they would think would be necessary?
Dr. Brown, I missed the age. How old did you say the patient is?
She's a 12-year-old female.
Okay.
Yeah, and it appears she has a lot going on. Uh, and once again, to couch this all as ADHD and Tourette syndrome, I think is they're being a little slim, but we'll proceed. Trauma history, abuse history. The patient denies any past or present physical, sexual, emotional abuse of any kind. Medical history. There are no medical conditions reported. No known cardiac history. No past surgical history. The patient is of average height and weight. History of drug or alcohol abuse. The patient denies any past or present use of drugs or alcohol. Family history. Her parents were born in South America. They speak English very well. Her mother's a teacher and her father works in sales. The patient has been raised Catholic. She lives with her parents who are married. Her older brother is 14 years old, and her older sister is 16 years old. The mother does have a history of depression and anxiety and is currently on an SSRI. The patient's brother, who is 2 years older, has ADHD as well. The father notes that on his side of the family, there's alcoholism and ADHD. So it appears that genetically she is preloaded with some mood disorder stuff, um, ADHD in the family, and a history of alcoholism. So, any questions about the trauma, abuse history, medical history, substance abuse, or family history? Comments? Alrighty. We'll go to the personal history. Uh, Perinatal, the mother denies any drug or alcohol use during the pregnancy with the patient. The patient was born a little early at 32 weeks. The mother had placenta previa and was placed on bed rest for the remainder of her pregnancy. The maternal age at birth was 31 years. The mother had a C section because of prolonged labor. The patient was in the NICU for 1 week. The mother denies that the patient had any brain injuries or seizures in the past. The mother states that the um, patient engaged in eye contact, smiled spontaneously, and had a happy disposition as a neonate, um, an infant. Uh, Her first learned language was Spanish, which she speaks fluently with her parents, and she also speaks English fluently. Um, Child and adolescence. The patient enjoys playing with her siblings, yet has difficulty maintaining um, friendships because of her outbursts and poor impulse control. Um, the patient is not engaged in any activities or sports outside of school, and she denies being sexually active earlier or now. All right, that's personal history. Any questions about the personal or developmental history? All right, we'll go on to the mental status examination. Appearance: the patient is well groomed. She's normal gait and posture. She's dressed appropriate for the season. Behavior and psychomotor activity. She does have head ticks during the assessment, most likely related to being nervous and a little stressed. Psychomotor activity is normal. She's neither hyper or hypoactive, outside of her tick activity. Consciousness, she's alert. Orientation, oriented to person, place, and time. Memory, recent and remote, are intact. Concentration and attention are impaired. Visual spatial ability is not assessed. Abstract thought, not formally assessed, but appears average. Intellectual functioning, she is of average intelligence. Um, Knowledge and awareness of events in past history are intact. Speech and language, her speech is slow but normal volume. Her ability to name objects and repeat phrases is intact. Perceptions, there's no abnormal perceptions apparent. are reported. The patient denies any past or present hallucinations or delusions of any kind. Thought process, these are coherent. Thought content, the patient uh, thought content appears to be negative because she's worried about her future, um, being transferred to another school. Um, um, Suicidal and homicidal ideations. She denies any current ideations, intent, or plan. Her mood is euthymic. Her affect is constricted a little. Impulse control is actually good during the interview. Judgment is impaired and poor. Insight, she does understand the need for hospitalization and why she's at the evaluation. Her reliability is fair. Okay. Does anybody have any questions or comments about the mental status examination and how she presented? Okay. Now we're going to move on to actually formulating the diagnosis. First question is, which diagnosis should be considered? The author here um, states attention deficit hyperactivity disorder combined type and Tourette's disorder. So we have two diagnoses here, but based upon her history, I think there's a lot more going on. Does anybody feel that way, or what do y'all think about the two provisional diagnoses, ADHD combined and Tourette's disorder, based upon how she presented?
I think she has more
Um,
going on.
Yeah, I think she has a lot more going on related to her mood and anger outbursts, and I think the author here is missing that, and she may be doing that on purpose as an exercise to make us go beyond what she's stating. My thought is that she may have disruptive mood dysregulation disorder. Um, I don't think it's ODD because she doesn't appear to be overly negative and defiant, but she just has some. Hold on, somebody has something going on in the background, so uh,
You think they didn't go with mood disorder because the Lamotrigine? She said that they didn't see a difference when they put her on it.
I don't know, but I don't think they had her on and that was a trileptal. I don't think they gave her an adequate trial, or they
Oh,
should
okay.
have gone to another. They should have gone to another agent. I think there is someone that has something going on in the background. They may want to either mute themselves or cut down that background, cut out the background noise. Um, but all right. Um, so let's go ahead and discuss ADHD a little bit. Um, hopefully everybody can still hear me. Um, let's look at the diagnostic criteria for ADHD combined type. It's a persistent pattern of inattention or hyperactivity, impulsivity that interferes with functioning or development. Um, it's characterized by six or more of the following symptoms that have persisted for at least 6 months to a degree uh, that is inconsistent with the developmental level and negatively impacts um, social, academic, or occupational activities. So these behaviors are developmentally are not developmentally consistent and shouldn't be seen at the particular age. And I'll go over a few of them um, um, just to give you an idea. So on the uh, On the inattention side, and it should note that the symptoms are not solely, these symptoms of inattention or hyperactivity are not solely a manifestation of oppositional defiant disorder, hostility, or failure to understand tasks or instructions. So, I mean, and that would put them in a different diagnostic category. So, under inattention, the individual often fails to give close attention or details or makes careless mistakes in schoolwork or at work. Uh, um, they often have difficulty sustaining attention in task or play activity. Um, they often do not seem to listen when spoken to directly. They often do not follow through on instructions and fail to finish schoolwork, chores, or duties in the workplace. They often have difficulty organizing tasks or activities. On the hyperactivity and impulsivity side, um, they often fidget with or taps hands or feet or squirms in their seat. They often leave their seat in situations when remaining seated is expected. Um, they often run about or climb in situations where it is inappropriate. Um, they're often unable to play or engage in legal activities and leisure activities quietly. Um, and they often talk excessively. So these are some of the sample behaviors you'd see in hyperactivity and impulsivity type of ADHD. And this person apparently has combined. Once again, the history and present illness didn't really present this, but the patient had a pre-existing history, so um, we're going along with that pre-existing diagnosis. But once again, there's a lot of other stuff going on top of that. Criteria B of ADHD is that several inattentive or hyperactive impulsive symptoms are present, and they have to be present before the age of 12. Several inattentive and hyperactive impulsive symptoms are present in two or more settings. So these symptoms have to be displayed in home, school, or at work. Um, there's clear evidence that the symptoms interfere with or reduce the quality of social, academic, or occupational functioning. Um, and the symptoms do not occur exclusively during the course of a psychotic disorder or any other mental disorder, mood disorder, anxiety disorder, or substance abuse, uh, intoxication, or withdrawal. So let's go over the rationale for this ADHD combined type diagnosis that is given here. The patient makes careless mistakes, has difficulty paying attention to detail, has difficulty sustaining attention and staying on task. She often needs redirection and reminding to complete tasks or chores. She feels overwhelmed and frustrated with her homework. She has difficulty organizing tasks. She has a poor time with management skills and overall concept of time. She avoids and dislikes tasks that required sustained mental effort. Uh, she feels more anxious when she's trying to stay organized um, and trying to finish her homework. She loses items necessary to complete the task. It is difficult and is often distracted by extraneous stimuli and is often forgetful in her daily activities. The patient also fidgets, leaves her seat, and is often on the go, talks excessively, has difficulty waiting her turn, and interrupts and intrudes on others. These symptoms are present in school and at home. Therefore, the patient meets the criteria for ADHD combined type. Now, in reading the rationale here, a lot of this information wasn't clearly presented in the history of present illness, but once again, uh, for the sake of the authorship, we'll just assume that these behaviors were pre-existing, even though I don't think that this is the reason, the main reason for her presentation to the clinic. Um, Does anybody have any thoughts on that? Hello? All right. All right. Can y'all still hear me?
We hear you.
All right, good. Just want to make sure you're there. All right, so let's go to the Tourette's um, disorder. Um, the diagnostic criteria for Tourette disorder: both motor and one or more vocal tics have been present at some time during the illness, although not necessarily concurrent. So you can have motor tics, eye twitching, shoulder shrugging, and you can have vocal tic, shoulder, which is coughing or saying, repeating words or repeating what someone else says, or even cursing, um, etc. The tics may wax and wane in frequency, but have persisted far more for more than a year. So the ticks have to occur over a year's duration, and the onset has to be before the age of 18, and the disturbance is not attributable to the physiological effects of substance such as cocaine or another medical condition such as Huntington's disease or post-viral encephalitis. Um, what is the rationale for this diagnosis? The patient exhibits both motor and vocal tics. The tics have persisted for more than a year, and the onset occurred before the age of 18. The disturbance is not attributable to the effects of a substance or another medical condition. Therefore, the patient's symptoms do meet the criteria of Tourette's disorder. Um, Anybody got any comments about the Tourette's? Uh, so I think she clearly has that because of her history of both motor and vocal tics. They clearly started when she was about 4 years old. Um, um, she's not really being treated for the tics per se, but she is on clonidine, and we'll talk about treatment for Tourette's syndrome. And the clonidine could work both in her ADHD as well as her Tourette's disorder. Um, so, what tests or tools should be considered to help identify the correct diagnosis? The author here puts the Child Behavior Checklist Attention Problem scale, the Connor rating scale, and we use that a lot. The Connors abbreviated symptom questionnaire, um, the disruptive behavior disorders rating scale, um, um, and the DBD structured parent interview. So it is important to obtain information from both parents and teachers uh, uh, who have observations of the patient's behavior throughout the day and throughout various activities, such as talking to various teachers, especially if the patient changes classes, babysitters, or other significant adults with whom the patient is in contact with. Um, the Vanderbilt rating scales, both parent and teacher versions, can be used to identify ADHD. Um, and we use a lot of the practitioners that I supervise use the Vanderbilt rating scale more so than the Connor scale. A majority of children with ADHD have at least one other um, um, access one psychiatric disorder, and the practitioner should inquire about other symptoms of ODD, oppositional defiant disorder, conduct disorder, depression, anxiety disorders, substance use disorders, and mania. The assessment scales, such as the child behavior checklist and the SNAP 4 may help identify these orders. And I think in this particular case, um, they should have used these skills to really dig into an ODD, DMDD uh, diagnosis, because this child, I think, has a lot more than the ADHD and the Tourette's diagnosis going on. Um, so, what differential diagnoses are diagnosis should be considered? Um, um, let's see here.
Dr. Brown, I'm sorry. Can you tell me what scale it is you say most of your practitioners use? Did you say Vanderbilt?
Yeah, they use the Vanderbilt rating scale, the one for parents and the one for teachers, in order to support the diagnosis of ADHD in children. And we take a baseline, and then every 90 days, I ask them to kind of have the parents and the teachers, if they have time, to do it again, so we can at least track the disorder and the improvement with the medications that we're using.
And where do you
And to,
access it? Is that something you can pull up online? The Vanderbilt rating scale?
yeah, you can actually go to www dot nichq.org. www.nichq.org. That's a pretty good scale. It's a little meaty. The Connor scale is a little easier and to fill, and you may get more utility out of that because it's not as detailed as the Vanderbilt scale. But the Vanderbilt scales is rapidly becoming the standard. Um, so let's look at the differential diagnosis real quick. As previously noted, it is important to assess for comorbidities that can occur with behavioral issues. Appropriate differential diagnosis would include ODD, oppositional defiant disorder, conduct disorder, or an impulse control disorder, which I think this young lady does have an impulse control disorder, the DMDD. At the time of presentation, the patient's symptoms did not meet the full criteria for any of the DSM-5 disruptive impulse control uh, and conduct disorders, ODD, or intermittent explosive disorder. But I think, once again, I think the author missed a possibility of DMDD, because this young girl, she, she gets easily upset with minor triggers. She kind of stays angry and moody most of the time than not, and little things just trigger her. And she hadn't had gotten into any real physical altercations, but she makes all of these threats to hurt somebody, kill somebody, blow up the school, or whatever she says. So, and I think that's because of a rush of anger, rage, hostility that I think is more than just attention deficit disorder. Um, so let's formulate a treatment strategy, based upon what the authors here have diagnosed. Psychopharmacology, their recommendation here is Stratera, 40 milligrams in the morning. Stratera was initiated to treat the ADHD symptoms because this patient did not have a satisfactory response to clonidine. Um, when our clonidine dose was increased, she became sedated. So the lower dose of 0.25 was resumed. Um, and when she was tried on the methylphenidate extended release tablets, her tics became more frequent, and she was not able to tolerate the side effect. Therefore, a trial of Strattera was indicated because it can be used to treat ADHD. Um, However, the first line treatments for ADHD include stimulants, then Strattera, and the guavacine extended release or clonidine. There is conflicting evidence about whether stimulant medications contribute to tics. It is important, as with any medications, to weigh risk and benefits. And the parents of the patient in this case study specifically were unwilling to try another stimulant for her ADHD because of the worsening tics in the past with the trial of the methylphenidate extended release tablets. So the take home point right here is that stimulants are still first line for ADHD, but if the person does have a history of tics or some side effects, it may be better um, to move along to Stratera and to also look at the old standard of guavacine, Intanev, or the clonidine. Um, Amoxetine is a selective norepinephrine reuptake inhibitor, an SNRI. It works by increasing norepinephrine and noradrenaline, um, and also possibly dopamine in the prefrontal cortex. So it activates the frontal lobe to kind of filter what's going on in the limbic system and the basal ganglia area and kind of keep all that abnormal movement kind of quiescent, and also keeps the frontal lobe kind of nice and focused so people can focus on particular stimuli in the environment and stay away from being distracted by extraneous stimuli. The Stratera is approved by the FDA for ADHD in adults and children older than 6. The onset of action can occur as early as the first day of dosing. However, therapeutic actions um, may continue to improve over 8 to 12 weeks. In this case, we also continued the Lexapro 10 milligrams a day. She has responded well to this medication for anxiety symptoms from the 5th grade, and so it was continued. Um, they do suggest considering discussing a trial um, of a stimulant for this patient in the future with the parents. Although the patient's tics increased when tried on the methylphenidate in the past, research has not established a clear causal relationship between stimulants and tics. It is known, however, that tics occur more in patients with ADHD. So, does anyone have any comments on the pharmacologic treatment strategy with this particular patient? This is a good case because it illustrates where you should bypass a stimulant and go straight to Stratera. Anybody got any comments about that? Or
So in this case, I can see like you said, bypassing the stimulant, but I in the practice, you're saying the first line of treatment is a stimulant, and so that's hard for nurse practitioners since we can't write for stimulants.
right, and that's a big thing going on right now here in Georgia and in some of the other states that we operate in. The nurse practitioners and PAs are not able to write stimulants, so they generally have to get their collaborating physician to write these meds for them. Um, but you know, and the literature does say, hey, stimulants should be the first thing you try. But there is an excessive amount of stimulants being written, so things may change, and it may be better to try a little clonidine or guavacine, particularly if the patients have the hyperactive um, type of the ADHD, because those medicines work really well with that. And add some Strattera on if there is some problems with inattention. But if it's a situation where the kid is just daydreaming, can't stay focused, um, the stimulants appear to be the number one drug to use in that case. So you're probably going to have to get your collaborator involved in that care. But there's a real big push now to, particularly with controlled substances, to have face-to-face evaluations and to have those patients be seen directly by the prescriber. So um, these kids
Wow.
will probably end up having to go to either to their pediatrician or primary care doctor, or if there's a psychiatrist available uh, to see them and write the script. That may be as going into the future. That may be the way that these cases are gonna have to be managed until we figure something else out.
Okay. Thank you.
Yeah. Um, any other comments about the treatment plan, the pharmacological treatment plan? Uh, if I were the diagnostician here, I would have probably gone and made a diagnosis of disruptive um, mood disorder and um, the DMDD, and I probably would have gone with a mood stabilizer. I would have tried some Lamictal because these outbursts that this young lady's having and her moodiness is those symptoms are too prominent not to be recognized and coalesce into a formal diagnosis. And I would have probably tried that to see if I could take care of that particular symptom set. Because I think if they're assuming that all of these outbursts are related to ADHD, I think they're going to find that the Strattera may not cover that behavior. Because she's already on a SSRI for mood, and that's not working. Um, and I think adding the Strattera may or may not help, but I think a formal mood stabilizer may be useful. And there are other things that we could use, like Risperidol or some Seroquel. But since those block dopamine, and she needs the dopamine for her frontal lobes to maintain her attention and keep her hyperactivity down, I think using an atypical may not be the best. So a standard mood stabilizer should be tried. And I think when they put her on the trileptal, I don't think they used it very long. They should have either upped the dose or gone to another agent. So I think that may be a misstep in this particular case. And this young lady may not be in the current situation of having to go to an alternative school or be homeschooled and having to be placed in a partial hospitalization program. So I think a mistake was made. Does anybody have any feelings about that in this case? I mean, if they had the patient, all right. Diagnostic test, comprehensive baseline blood work panel was ordered to establish safety before initiating medication. The patient had a 12 lead EKG that was ordered to set a baseline. There are varying recommendations regarding screening of cardiac structural abnormalities without any known history because of the potential for for undiagnosed cardiac abnormalities like Wolff Parkinson White syndrome, hypertrophic cardiomyopathy, and a prolonged QT syndrome. The potential for sudden death with Strattera, with the potential for sudden death with Strattera, the testing was done. So basically, if you're going to start a kid on on any one of these ADHD meds, the Strattera or any stimulant, you need to do a cardiac workup just to establish a baseline. Um, um, it is recommended that to monitor the blood pressure and pulse when initiating treatment um, until the dosage uh, uh, increases are stabilized, because the Strattera has a potential for adverse effects on the cardiovascular system owing to its norepinephrine effects. Once again, Strattera it's not a SSRI, it's a SNRI, and increases norepinephrine um, selectively and specifically. Referrals, the patient was admitted to the partial hospitalization program, where she will be receiving individual, family, and group therapy. The patient was receiving homeschooling services via school and was being assisted um, with looking at options for a therapeutic school that will provide her with a smaller classroom size and more individual attention to allow for increased success in the school setting. So she was either going to be sent to a different school, an alternative school with smaller classes. The type of psychotherapy: behavioral parent training, behavioral classroom management, um, behavioral peer intervention, neurofeedback training, and organization interventions will be should be utilized. As far as psychoeducation for the family, Strateric carries a black box warning for increased risk of suicidality in children and adolescents with ADHD, especially during the first few months of treatment. The patient should be monitored closely for increasing suicidal thoughts or behaviors, clinical worsening, or any unusual behavior. Yeah, I had one child one time. We started him on a SSRI, and for some depression, or an SNRI, either one, and he started jumping out of windows. So you really got to watch. It's not going to be in all the kids, but you got to watch them. They become a little more daring, and if they have an underlying suicidal kind of diathesis going on, that can definitely be worsened with these SSRIs and SNRIs. Uh, the patient and parents should be referred to the child and adults with attention deficit hyperactivity disorder support group. Um, what are some of the standard guidelines we would use to treat or assess this patient? The American Academy of Child and Adolescent Psychiatry practice parameters for ADHD. That's one guideline set. And the American Academy of Pediatrics clinical practice guidelines for children and adolescents with ADHD is another guideline. On clinical note, uh, we need to realize that aggression is a frequent symptom of children with untreated or undertreated mental health conditions, including ADHD. Beside a morning dose, additional afternoon doses of Strattera may be needed to provide full-time daytime coverage of ADHD symptoms and maintain focus in the home as well as a school setting. So it looks like the Strattera can be given once a day, or you can break up the dose and to cover morning and afternoon periods of inattention or hyperactivity. So it looks like the Strattera has some immediate onset and has some long-term effects with it as an agent that can be utilized. Um, After treating the ADHD appropriately, it is prudent to monitor for any other remaining mood instability or behavioral issues that are unrelated to unmanaged ADHD, and assess the need to administer further psychotherapeutic and or pharmacologic interventions. And once again, in this case, I think they didn't go far enough because there were some other symptoms that really needed to be addressed in this case. Does anybody have any questions or comments about this case study?
You said a cardiac workup, so the only thing is the 12-lead EKG is what we need to get prior to starting the
Yeah, I
Strattera?
would. Yeah, I would get. Yeah, for either the
Oh,
Strattera and or the stimulants, I'd get an EKG. I'd get the pediatrician to get you one. And what we have a set of control substance and scheduled drugs policies and procedures, and under the stimulants, um, we ask that the pediatrician or primary care doctor actually allow for medical, actually give us a medical clearance note. Um,
okay, that's for the stimulant, or is that for both the Strattera, the non-stimulant and the stimulant?
it's for both, you know.
Okay,
Yeah, it's for both. Uh, um, yeah, it's actually for both. Um, um, yeah, because there's going to be a certain portion of these kids that may have some cardiac issues,
okay.
and when you give them these medicines,
Now,
they're
would the
going to cause
pediatrician have
problems.
to be the one to order the 12-lead EKG, or can we do it?
It'd be better to let the doctor do it because once you break it, once you break it, you bought it. So if you order the EKG, you're gonna have to be the one responsible for reading it. So
Oh,
yeah,
okay.
and writing out the yeah. So you need to let the pediatrician do that, just in case something goes wrong. It was
Gotcha,
his read and not yours. All right.
gotcha. Makes sense. Hmm.
Yeah.
But this is only the non-stimulant atomoxetine or Strattera, not for guanfacine or clonidine, right?
Well, yeah, but I mean, I would just get it no matter what because you don't know what you're going to end up moving to, you know. Um, so if you're starting off with the person's a little hyperactive, and you want to put them on some clonidine, um, but you don't know if they're going to end up being on a stimulant or SSRI and then SNRI, then yeah, these are just baseline things. I would say, as soon as the kid has a diagnosis of ADHD and you know you got to move to a certain class of drugs, I'd go ahead and get that EKG done just to have it there, say it's cleared, so the field is clear for you to move through a series of pharmacological agents. ADHD, unfortunately, as an isolated disorder, is one of the few diseases where the primary intervention is pharmacologic and not psychotherapeutic. I mean, all the literature says you got to start off with a stimulant, and that's, and I mean, it's unfortunate, but that is how this disorders to be managed primarily. You got to activate the frontal lobes, and the best agent to activate the frontal lobes are stimulants. Um, you can try other drugs such as Effexor. You can try a little bit of Wellbutrin. There's also one of the older um, antidepressants, disipramine. All of these drugs, they raise norepinephrine and dopamine, and those are the agents that activate the frontal lobes to improve attention and decrease hyperactive behavior. But the old standard and the best pharmacologic tool we have right now are the stimulants for these kids. I always say, try to give the lowest dose you can. You may have to do a little bit in the morning, do a little bit in the afternoon, and if you can, give them drug holidays on the weekends and during the summers if it's possible. But the kids may have so many attendant behavior problems outside of being hyperactive or inattentive that most parents and school officials, or at least the parents, want them to be on the medication, you know, 7 days a week and throughout the summer. But uh, it's good to give to give the brain a break from that from that getting that extra dopamine and norepinephrine kind of pushed on top of them. I'm gonna do go over some quick questions here. Um, got a
Yeah,
case.
I, I had a quick question.
Uh-huh.
Yes, I
Go
wanted
ahead.
to find out, like, on this case right now, say, you do the EKG and the QT interval is already prolonged, and with the outburst, we say we can go the route of stimulant, and considering, Georgia's laws and all of that regarding that. So at that point, what would be the alternative for this patient, considering that the Stratera can actually make even the QT interval even worsen,
Mhm.
and you do the EKG and the EKG is already prolonged. So what would be an alternative route to go on the case?
In that case, you could use it's according to what the abnormality is in the EKG, but you could still use a stimulant, and you may be able to use the guanfacine and the clonidine, or you could still use the Strattera. You just got to watch the dosing, and um, you just got to look for any symptoms, any hypotensive episodes, any um, um, fainting, and you may just want to get some serial EKGs just to see what the effect that that drug does have on aggravating that QTC that QT interval. Um, um, but the best thing would be just to consult and work closely with the pediatrician and or the primary care doctor on which medication to use based upon what the EKG does show. Um, 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 those would be your options. um, and each drug affects the cardiovascular system kind of in a different way. Um, so once again, um, you may want to the pediatrician may want to do some additional tests, uh, additional cardiac workup, and give you some more information that could help guide your hand in which pharmacological agent to to pick out of those three classes: the stimulants, the alpha two agonists, which are the clonidine and the guanfacine, and um, and the SNRI, which is the Strattera.
Okay, thank you.
Yeah, yeah, yeah. Just you got to work with the pediatrician. Let me see if I can find this case here. I just had a few cases. There's some questions that relate to Tourette syndrome and ADHD that I want to go over just to hammer in some of the points that we went over. So, all right, and then I think this will be it. Let y'all go. We got a 9-year-old boy who presents with his parents for problems with his behavior. He's currently being treated for ADHD with methylphenidate, extended release, 36 milligrams. Looks like Concerta, 36 milligrams. They report that he has been doing well academically since starting the medication 1 year ago. However, he got into trouble for pushing a classmate. When asked about this patient, um, when asked about this, the patient reports that a classmate made fun of him because he sometimes makes noises that he cannot control. His parents report that he's been doing that since he was in kindergarten and that he blinks his eyes too much. So here are some multiple choice questions related to this case. What is the diagnosis or diagnoses? Um, we got several choices. We got disruptive mood dysregulation disorder, major depressive disorder, social anxiety disorder, stereotypic movement disorder, or none of the above. Um, which one do you think it is? Um, the answer is actually Tourette's disorder, which is not one of the choices, and it's Tourette's because he's less than eight. He's less than 18. He's 9 years old. Um, um, he's been doing well, and started. He was started on the ADHD medication a year ago. Uh, so it looks like these symptoms um, preceded that, and he's been having the the vocal tics, which is the noises that he can't control, and he also blinks his eyes too much. And these have been going on since kindergarten. So he's younger than 18. He's been having the symptoms for greater than more than a year, and he has both motor and vocal tics. Okay, so that qualifies him um, to have a diagnosis of Tourette's disorder. All right, what is the typical age onset of this disorder? We have A, 2 to 4 years of age, B, 4 to 6 years of age, C, 6 to 8 years of age, D, 8 to 10 years of age, and E, none of the above. And the answer is B. The typical age of onset for Tourette's disorder is between 4 to 6 years old. Um, third question: um, which of the following is treatments is appropriate for this patient? We got CBIT, DBT, CBT, EMDR, or none of the above. Now, we didn't cover this in the case before, but CBIT, which is Comprehensive Behavioral Interventions for Tics, is the initial treatment if someone has a diagnosis of tic disorder. Um, it's a behavior modification, psychotherapeutic intervention, and unlike ADHD, where the initial treatment is medication, in Tourette syndrome, the initial treatment is either one, observation, or two, employing CBIT. You only want to start medicating a Tourette's disorder with the tics, only if the tics are really, really bad and are disruptive. So that's that one pearl there. Question 4. The patient's parents calls after a friend told them that they shouldn't have their child on ADHD medication because ADHD medications could make their condition worse, the tics. What would be the most appropriate thing to tell them? A. Current evidence shows that there is an association of stimulant ADHD medications making the tics worse. Current evidence shows that there is no association of stimulant medications making the tics worse. C. Current evidence shows that there is an association of non-stimulant medications making the tics worse. D. Current evidence shows that there is no association of non-stimulant ADHD medications um, making the condition worse. And the answer here is 4. Current evidence shows that there is no association of stimulant ADHD medications making the condition worse. So I would just, use this as a caveat. If someone has a pre-existing history of a tic disorder or Tourette syndrome, I would bypass using a stimulant medication and just go straight to Strattera and or the alpha 2 agonists such as clonidine or guavazine. Um, even though the literature is saying there's no correlation between stimulant medications and worsening of tic disorders, I would just personally avoid them. 5, what is the peak age of severity of Tourette syndrome? We have 6 to 8 years old, 8 to 10 years of age, 10 to 12 years of age, 12 to 14 years of age, or none of the above. And the answer here is C. The peak severity of the disorder is between 10 to 12 years of age. So Tourette syndrome may begin. You see the first symptoms at 4 to 6 years of age, but you get the maximum tic activity between 10 and 12. And the final question here, and then I'll let you go. Which medications would be the most appropriate first step treatment option if the patient's condition requires medication and you want to minimize the possibility of any metabolic side effects? You got risperidone, aripiprazole, haloperidol, clonidine, none of the above. The answer here is D. Clonidine would be the most appropriate treatment. It's an alpha 2 agonist and it doesn't have the side effects of the risperidol, aripiprazole, or the haloperidol. Okay, so that's just the standard. If the CBIT if the observation doesn't work, then you go to CBIT, which is a psychotherapeutic intervention. If the tics still uh, are worsening, then the first pharmacologic agent that you want to try and to rest would be clonidine. And if the clonidine doesn't work, then you may want to move to uh, the antipsychotics or the antidopaminergics, such as Haldol, Risperidol, Abilify. Okay. Anybody got any questions about this case study or the questions we just went over related to any of these cases? I know this, we kind of went all over the place with this case: ADHD, Tourette syndrome, DMDD. And a lot of times the cases will come to you multi-layered like that, and or you just don't know what's going on and you got to work your way through them. But and that in this case in particular kind of displayed that. Um, any questions at all?
No
All right.
questions.
No,
All
thank you.
right. All righty. All right. Well, I think I took enough of your time. I know you guys got to get back to clinic, but thanks for attending. And I'll probably go back to something real basic like schizophrenia or post-traumatic stress disorder on our for our next case study. Okay.
All right, thank you.
Thank
All
you.
right then. All right. Bye
Thank
bye.
you. Thank you.
Thank you.